perspectives you can. So we're going to talk about it from various different perspectives, a little bit from the patient perspective, but also want to add a little bit of culture, what culture is like to providers, things like what happens when providers get discriminated against and what happens there and what we do with that, and then sort of community level cultural aspects to consider too. So I have no disclosures, but I do always give this fair warning that I encourage some audience participation at some point, though I pared down that a little bit from maybe what you have in the handouts. So we'll start off with a little bit of that, actually. But I'll first tell you a little bit about myself and why I'm doing a presentation on culture and sort of where I come from with that. I grew up in a small town in North Georgia called Dalton, across the state line from Chattanooga, if you know, that might help kind of place a little bit better. That actually has a majority Hispanic population, so I grew up around a lot of diversity, a lot of immigrants who would come in. We make a lot of carpet in Dalton, so that made a lot of good jobs that brought in lots of immigrants over the years. So I grew up around a lot of Hispanic culture, and then went to college in Evansville, where I met my wife on the first day I was there from Argentina, and decided I wanted to be around her, so I got involved with the students club there and learned a lot about culture there. Ended up eventually coordinating a cultural exchange program where we paired domestic students with international students, and sort of headed that up and worked with some of those experiences there. Then went off and got my doctoral training, which was just pretty standard training, nothing special around culture there. But when I went to my pre-doctoral internship, which is more akin to like the residency, as you all know, I got some specialized training. I was working in Hartford, Connecticut, in a very urban population, which is, again, there weren't very many people that looked and that. So focused teaching on that throughout the whole year I was there. So now I did another fellowship there in integrated primary care, working with physicians and dentists and other kinds of health care professionals, and now came here and teaching here. So thank you all for welcoming me. A little overview of what we're going to do today. We'll start off with what is culture, and then, as I said, we'll go through the patient perspective, the provider perspective, and then a more perspective. First, this is the audience participation part, just kind of testing assumptions. You look at these different kinds of people, imagine them being patients coming in to see you in your practice, and we all form immediate first impressions about people, and it's going to happen no matter how hard we try to fight it. So I'm going to ask you for a minute to sort of remove the glasses of political correctness and what you think you're supposed to say, and just kind of think about out loud. What are some of the first impressions that come to your mind as you see, let's pick this guy here in the corner. What might you think about him? What's he like? What does he do for a living? What kind of patient might he be? He's still learning. He looks pretty average. Yeah, what do you mean by that? What kind of average? Meaning he does like an average job? Yeah, if you had to guess at what he does for a living, what would you say? You'd say he's a graduate student. He looks like a graduate student? Yeah. All right, let's pick another one. What about this guy here? What's he like? What's he do for a living? He's president of his fraternity. What kind of patient might he be? Let's say he's coming in to see you. What are some things you might expect him to be coming to see you about, just based on this picture? Yeah, maybe he has an alcohol problem. What else? Yeah. Yeah. All right, let's do one more. Let's do this sort of androgynous looking, maybe not androgynous is a poor choice of words. I'm not sure if this is a male or female. Let's call it that. Let's just put it that way. I'll put myself out there and say that. You can't tell by looking at them. So what do you think? What are some thoughts about what this person does? What are they like? What kind of patient is he or she? A librarian. Kind of looks librarian-like. Secretly a serial killer. Okay, animal rights activist. Animal rights activist, serial killer, kind of the same thing. All right, all jokes aside, we'll take that off. What is culture? How do some of you define culture? What are some of the things you think of when we start talking about culture? Okay, background that you're raised in. Good, I like that. Let's stick with that definition, make it simple. Sometimes when I give these presentations, people say your race, sometimes people say your family background, focus on different specific things. But one of the things about today is that culture is really any kind of attitude that's important to you and it's important to you because it's something about your belonging to a particular social group. So here's some of the definitions from the dictionary. This is the definition that I give, as I said before, anything that's important to a person as a result of his or her belonging to a certain group, whatever group that might be. And so cultural competence is a big part of what we talk about in our field. I talk about it a lot with my students over in the psychology department at the doctoral level and even at the undergraduate level. And it's something we're forced to incorporate into all of our courses, and we talk about how do we talk about culture in this course, and we put it in our syllabus and all that stuff. So it's important to define what actually I mean by cultural competence. And there are varying definitions, just depends on who you ask. But the most often cited one is called the tripartite model from Sue and colleagues, or Sue and Sue, and are the sort of main people within our field, at least, that research this and write about it for a long time. And so they define this tripartite model as having to look at someone's knowledge, skills, and then their attitudes and beliefs on these three different levels. And then within these three domains, they talk about a culturally skilled clinician does these specific things that you can read up here. So they become active in becoming aware of your own assumptions about human behavior, values, biases, and so forth. So that's the first step. The second one is then you actively go to try to understand the worldview of every different client without any negative judgments. And then the third step is then that you begin to develop and practice appropriate, sensitive intervention strategies and skills that are targeted towards your clients. And so again, you do these on these three different levels: in your knowledge, in your skills, and in your attitudes and beliefs. And I'm not going to go into a whole lot of details of this model, but this is just sort of an overview of kind of what we're looking at, some background information and some citations of people who write about this. There's been a lot of research on whether culture matters in healthcare, and really this is another thing where it depends on who you ask and how you ask of whether it really does matter or not. It also depends on how you define culture. A recent meta-analysis in 2015 found that multicultural competence, so looking at the competence of the provider, really is only fairly weakly associated with therapy outcome. In this case, they were looking at psychotherapists. Although I will say from other studies, this is fairly consistent with other kind of practitioners too, which we'll see in a little bit. And so the competence itself is really not as big a deal as more general clinical skills like developing a working alliance, just general counseling competence in this case. That was much stronger. So what that meant is that if you had generally good clinical skills, and you also seemed to translate well to being fairly culturally sensitive. I did some research on my residency where I specifically looked at, we were implementing a therapy called trauma-focused cognitive behavioral therapy. All of you aware of what this is? More or less? Yeah. And so we had this huge problem all throughout the state of Connecticut. They were trying to implement this throughout the state, getting different agencies trained and doing this accurately and with fidelity. But we were finding throughout the whole state that there were, in specific agencies, there was just a huge variety in how well people were doing at being faithful to this model. And so I was curious to find out why this was. So I looked at a lot of different factors. I looked at the therapist factors, or their background, their demographics. I looked at some supervision factors. How were they being supervised? Was it just sort of a group? Was it individual? Were they doing role modeling, or were they just talking about it? Role plays, those kinds of things. And then looked at client-based factors, things like their demographics, their diagnoses, their PTSD severity, both at intake and then at the outcomes and those kinds of things. And found, I will give the caveat, this is a relatively small sample study and a small, it was only at one agency, but did find that the only thing that really did predict outcome, which again was the percent adherence to the model, was the match between therapist and client ethnicity. So in other words, what this translated to was that, at least with respect to TFCBT, and I suspect it branches out to other kinds of clinical approaches as well, is that if the therapist and the client both perceive themselves as being sort of culturally similar, they're able to engage in this endeavor of clinical work a lot more smoothly, with less barriers, less other stuff comes up that sort of takes them away from the goal at hand, which in this case was implementing TFCBT. But again, I will say the caveat, it's a relatively small sample study. I do need to expand it and replicate it. Because I had so many factors in there, I really need a ton of participants to be able to do what I need to do statistically with it. But nonetheless, some interesting results. All right. So what does this mean then about what we should do as practitioners? And I kind of want to just touch briefly on the cultural interview. I'm sort of coming in this with the assumption that most of you have had at least a basic background in what it means to do a general clinical interview, and in fact to consider culture. And so I won't spend a lot of time on what is a cultural interview and what that means, but generally what I always recommend and what the literature recommends is that most techniques that work in a general clinical interview, so being empathic, being a good listener, having this non-judgmental attitude, applying interventions in a sensitive way, and then balancing sort of your how much you direct the appointment or the session versus how much the patient directs it, just finding the right balance in that. All of that also applies to the cross-cultural interview. But in the cross-cultural interview, you do pay extra attention to these cultural and social class differences. And this occurs during observation, and then in actually thinking about what the interview content, what's being said, and then managing the interview process. So we're going to look at a little bit of details on each domain there. The first question is whether whatever behavior you're observing, is that behavior pathological or is it just a cultural norm? Now this is a question that comes up a lot. And so some of the basic kinds of things that we talk about are whether the client averts eye contact. Do you interpret that as being evasive of social connection, or is that just an aspect of their cultural background and what they were taught? You don't make eye contact with people who are more powerful than you, so to speak, or on a higher level than social ladder than you, which we as doctors and providers often are perceived as being much higher on that social ladder. And so they may avert eye contact for that reason or for many other reasons. And so we have to sort of consider if a patient who is from a cultural background that doesn't make eye contact, if we're evaluating them also for other kinds of social awkwardness, maybe autism kind of thing, or psychotic behaviors or things like that. How do we consider what does that behavior look like in someone who's from this cultural background, and how do we consider eye contact and things like that? And so you just kind of have to do a little bit of extra work then to think about what's this look like within their culture. There's others, similarly, there's idiosyncrasies of language across cultures. Some people use words that we would consider to be sort of weird usages. And again, that might be considered a psychotic type behavior by some, if you're not careful to think about, is this a cultural kind of thing? Sometimes people whose first language is not English uses a word that they think is perfectly accurate, and it doesn't mean anything near what they meant for it to mean. And that can become confusing. So just thinking about that. And then again, does whatever behavior you're observing, does that reflect social class behavior? So as I mentioned before, sort of differences between how they're supposed to behave with someone who's considered to be a higher level than them, or even gender class behaviors like we're going to see later, I guess I'll go ahead and ask the question, within Muslim culture, who knows sort of how is a male supposed to greet a female in Muslim culture? Does anyone know? No. Not at all if they're unaccompanied. So males and females in traditional, let me reverse that. This is not true of all Muslim cultures, but traditional conservative Muslim culture, males and females are not supposed to touch. And so the way I would greet someone if I had an idea that they were a traditional Muslim female is I just put my hand over my chest and look at them and say hello, things like that. That's a show of honor and respect. And so just kind of knowing those kinds of things. So knowing if someone from that culture background comes to see you and they refuse to shake your hand or they look at you funny or they do something like this, and just knowing that's not necessarily weird, it just might be a behavior that's typical of their cultural background. Okay, another thing, this with regard to specifically with pediatric practice, are differences in parenting behaviors across cultures. And there's just very different norms in what parents are supposed to do and what they're not supposed to do. A big hot topic right now is co-sleeping and things like that, where and we're starting, I guess the reason I say that that is a hot topic is that now in Western society this is starting to be something that people consider as an option, whereas in the past it was really not, it was frowned upon, quite frankly. Whereas in other cultures it was just sort of normal kinds of things. In Japanese culture, for example, they co-sleep for up to 2 years. And that's pretty normal. And so just thinking about these parenting behaviors and as you're talking as providers to people from different backgrounds and maybe giving recommendations, of whether they should or not sleep with their baby in their bed with them. And thinking about if you're telling them this, then how can you give them this medical advice and still respect their cultural background and thinking about those kinds of things. We're going to look later when we get into some legal issues about some other parenting behaviors, so I'll come back to that. And then lastly, there's some different developmental observations that might come, and this is again more true of what we'll see in pediatric practice, although you could be looking at developmental things in adults occasionally. But we do know there's some slight differences across cultures. For example, we know that multilingual children do hit language milestones a little bit differently. Again, it's so slight that we're not talking about kids that have language that don't have any words by 18 months. That doesn't mean that they do have a language delay then. But usually we know that kids of multilingual children will use less words in each respective language they speak. They'll have sort of more total words, but in each individual language they have less than sort of a unilingual child. In some other cultures you can see differences in walking, talking, other developmental milestones. For example, if you go out into some more, some of the tribal cultures in Africa, for example, they carry their children around for almost 2 years and those kids don't really walk very much, or vice versa. They start walking when they're really little because they force them to do it. Same thing with potty training. I've heard about other tribal cultures that when they don't really bother with potty training. They just carry their babies around all the time, and when the baby's ready to poop, they just learn that it's time, and they hold them out, and they go, and they bring them back in. It's kind of an interesting thing that happens. It's sort of, I wish when I was raising my daughter, I had that intuition to know right when she was getting ready to go, so I could avoid lots of messes. But in any case, if we look at different research across these different cultures, you do see some slight differences that really mostly shows up for people like me when I'm doing a more detailed, comprehensive developmental evaluation, for example. They don't show up very often, say in like a primary care visit where you're really just, you can see it observationally. These things come up more often in these more advanced testing situations. The next level, so that's observations. The next thing to consider is the actual content of what they're telling you in an interview. And again, there are some differences in values among cultures about what they should and shouldn't say to a relative stranger. And so one big difference that happens a lot is that some cultures just have this different value on traditional and folk approaches to medicine and healthcare. I'm relatively new to the Appalachian area, even though I grew up in North Georgia. It's still different than Appalachia. But from what I hear around some of the more rural areas, there's this real belief in sort of keeping it in the family, keeping things sort of local, and trying to manage their health care within that. And, so as a result, they don't go to the doctor very often, especially for more minor kinds of things. And so this happens all across the world. People have these beliefs that when I get sick, it's better to take care of it in the way that I'm used to rather than maybe take a medication or go to therapy or something like that. And so we have to think about that as providers too, and when we're talking to these patients and saying, how can I communicate what I think they need as a clinician and sort of bring them on board with that that's sensitive to their cultural background and what they expect. As I alluded to as I started this section, there's a lot of variance in people's willingness to share information with a stranger, especially if that person's of a different social class. And so if we as clinicians really think it's a luxury to get all this kinds of information from people. I train doctoral students now, future psychologists, and I talk to them all the time, and they say things like, well, how do I ask someone about their sexual orientation? And I say, well, in our culture, one of the luxuries is that people are sort of used to doctors asking them questions that other people don't. So you can just ask them, and that's okay. But that's not always true. Sometimes you have other cultures where families and patients are really not used to that. And again, someone asking them such an intimate question would be pretty invasive. And so you have to consider those kinds of things. How do different cultures express emotion? That's another thing that's important in psychology and psychiatry. It's a big part of how we evaluate people, is their affect and their emotional expression. And so it's very different to say someone has a sort of flat or blunted affect within our culture versus within a different culture where it's pretty standard that they're just not very emotionally expressive anyways. And so again, thinking about that, do they come from a cultural background where you just don't show your emotions? And what does that mean? Does that mean that they have blunted affect, or does it not? All right, another one that's really important to pediatric work are family values and family roles. Who do you talk to in the family? When a whole family comes in to see you all together, who are you supposed to address first? Is it okay to address the child, or should you address the parents or or anyone else? Should you address the dad? Should you address the mom if they all come in together? So thinking about that, and then not just addressing them, but who do you give the recommendations to? Who do you talk to about what you're actually doing in treatment or in your evaluation? And then lastly, our religious values, and there's such wide variance on this that I don't have time to cover it all. I basically keep a book in my office of, I think it's called My Faith, My Culture, and Healthcare or something like that. It just has like a 2-page review of hundreds of different religions and what they expect in healthcare and things like that. So the reason I share that is that another thing that can impact healthcare are what can people accept in their religion, and do they come from a religion that allows them to use medication? Do they come from a religion that allows them to be depressed and to talk about depression without also talking about things like devils or demons putting these emotions into their mind and things like that? And if they talk about that, is that psychotic or is that cultural or and so forth? So again, just thinking about these things are, and most of what I'm sharing here is just kind of giving you a background of things I want you to think about rather than really give you guidelines of what you should or shouldn't do. All right. The last level, so we talked about observations, we talked about the actual content. The last level is the process of the interview. So, what's really going on behind the scenes, and how do you manage those? So I've already referenced most of these. Who do you address, considering those family roles? How do you address the patient? We talked about, how do you, difference in greeting standards. Also, another interesting one, I hate to keep coming back to Muslim culture, but I know that one well because that was a big part of some of my the undergraduate experiences I was talking about. Which hand do you use to shake hands with when you can touch in traditional Muslim culture? Anyone know? Right. Right is right. And the reason for this is because the left hand is the hand that you use to clean yourself with, and so you also don't eat with your left hand in traditional Muslim cultures, things like that. So just remember, right is right. So so that just knowing some of those differences and what that can mean to patients when you know that. and when you do it right the first time, and they don't feel like they have to teach you. Having said that, it is okay to learn from our patients and to ask them to teach you if you don't know. And in most cases, they won't get too much in a tizzy about that. And then, what level of autonomy is allowable for your patient in his or her culture? There's lots of cultures that are really strong in the family. As I said before, they don't make decisions for themselves; they make decisions as a family, and that's true of any decision, but it happens a lot in medical decision making and things like that. And so that brings into questions of how you might manage HIPAA laws in various cultures and things like that. What information can you share with the family? How do you get that information? If they're telling you that they want to make this decision as a family, then maybe it's a good idea that you do bring the family in and actually talk to them with a clinician so they understand where you're coming from, and you also understand where they're coming from, and those kinds of things. All right, I'm just going to skip through this. I'm not going to have you participate in this question section. But a question that comes up for me often is, well, how do you actually ask kids about their culture? Kids vary a lot in how much they can say. If I were to say, tell me about your culture to a 7-year-old, they'd give a very different answer than if I were to ask a 17-year-old. And they also may be very differently acculturated than their parents, especially if they were born here in the United States where their parents were born elsewhere. They just might have different expectations and different ideas about what they should do compared to what their parents do. So just considering that. Generally, one should avoid using children as translators out of respect for cultural norms. In lots of cultures, it's just not okay for the kid to do the talking in a session. So this happens a lot in places I go where there's just no one else available, so they ask the kids to translate. And just so if you're thinking about doing that, just consider also what that might mean about what kinds of information you're going to get. All right, some quick resources. I'm not going to click on these or show them to you, but just some suggestions for future learning. Is that APA does provide a cultural formulation interview. It's described in the DSM-5. I provided a link there. You can find it online just by searching cultural formulation interview, which is a nice training tool for new people who just aren't used to doing this kinds of things. So for students or things like that, I use it with my students a lot. And then if you're curious about your own level of multicultural competence, you can take a multicultural competence quiz. Those things are all over the place. I recommend one called the MCCAS, the Multicultural Competence Knowledge Abilities Scale. I actually don't know if that's what it stands for. It's something like that. But that's the citation. So the reason I recommend that one is it's one that's actually been fairly well validated as being an actual representation of your competence. All right. Any questions or comments on that section before I move into this special section on immigration? No. Okay. So I wanted to talk a little bit about immigration and healthcare, mostly because this is a really important issue now with the recent political changes. I see a lot of patients. I speak enough Spanish to get along. I don't use it professionally, but because of that, I tend to see patients that are Spanish-speaking, and most of whom are immigrants. And so I wanted to talk about immigration and what that means for healthcare. And you'll see here that I changed this. I found this little picture, and I purposely made this change because one of the things that is sort of a little pet peeve of mine, because my wife is from South America, that we call ourselves Americans and not people from the United States. And so I kind of changed that, the changing face of the United States. But again, that's to capture this idea of what I find is that many people from Central and South America do sort of come in with this idea that they are, we'll see in a little bit, sort of seeing some discrimination already, and even in the terms we use to describe ourselves as Americans. And so it's just sort of to bring to your awareness to think about this as you talk to people and think about your word choice and what that really means and how they're perceiving it. So I'm going to go quickly through all this. I'm not going to cover all this in detail. I can share the slides with you if you want it, but this is just some history on immigration, and basically what you need to take away from this slide is that there's been a lot of stuff that's happened in our history in the United States that have contributed to discrimination of immigrants. And even that has happened on sort of the legal side. So, for example, one of the earliest one, there's the 1875 Page Act that restricted access to what was called undesirable immigrants, and usually at that time that was from Asian immigrants. They had a few years later had a Chinese Exclusion Act where they wanted to limit people from China. Similarly, an Immigration Act of 1924 barred any migration from Asia and introduced quotas to limit other immigration. And you see some of these other ones coming along. Essentially, what this means is that we have the federal government has passed laws over the past 150 years or so that have talked about whether we want immigrants from certain countries and how many immigrants we want from certain countries and things like that. And because of that, that's created a culture within our country of people having this sort of discriminatory attitude towards immigration at times. And so you can even see some of these flyers from history that helped sort of contribute to that culture. And so immigrants come into the country with this idea of the sort of conflicted feelings about what they want to accomplish as immigrants, but also knowing that that there's a chance for discrimination. Here's some terminology stuff. Again, I'm not going to go through all this in detail, but there's such thing as there's a difference between permanent residents and temporary residents. The permanent one is a green card or called an LPR, lawful permanent resident. They don't have political rights, don't have no access to public benefits. And this is just because, even though they're called permanent residents, that doesn't mean that they can permanently remain. They have to renew this and update it regularly. And you can be removed even when you're on permanent residence. Temporary status includes everything else other than a green card, mostly visas, although there can be refugee status and things like that. You can apply for a visa under employment, education, things like that, or you can have a temporary protected visa, which is not employment-based, and that's what I was talking about before. That's for refugees and other immigrants who can't return to their home country. There's also a discretionary immigration status, which is basically it's a lawful status that's given to you by the president by some executive order. So this is a lot of what we have now with Obama's executive orders for the deferred action and that kind of thing, basically where he said, we know you're here illegally, but we're not going to kick you out. We're going to give you time to establish legal status, and that's what a discretionary one is. And so one thing to know about that is it's a very unstable status. It leads to a lot of stress for immigrants because they know that even though they have this, that it can potentially end at any time. And then the last one is an undocumented status. Of those, about 45% estimated did enter legally and then sort of fell out of status, and that's the highest level of ways that people come in. So what that means is they got a visa and their visa expired and they just decided to stay. So these statuses, as I said, have the highest associations with distress and healthcare avoidance. So they tend to not want to come to services because they think that might out them and get them deported eventually and things like that. Even though that, as we'll see later, that's not true. They can't get deported for these kinds of things, for coming to healthcare. Some other common issues for clients are that there are differences between state and federal laws about enforcement. So the federal government maintains entry and exit, and so they're the ones that decide who gets kicked in and kicked out, but the states determine access to social benefits, like whether they can get health care or whether they can get classes to learn English or other kinds of things. There's this other, the Anti-Drug Abuse Act of 1988 was really about drug abuse, but it also included this new term called an aggravated felony, which as part of that basically said that any non-citizen convicted of a crime can be deported if it falls within that definition. So they worked that into there. So that also creates some uncertainty about what would happen, what they might tell you if they feel like they have committed a crime, things like that. There are 6 states that do have laws that allow police to question individuals about their legal status. So if they get involved with police for some other reason, then in these 6 states, police can legally ask them, are you here? Are you a citizen or are you not? And then that can cause some problems. There are 3 states that specifically have trust acts that do the opposite. They prohibit police from being able to detain people simply due to immigration status. So you'll see, fortunately, that Tennessee's not on here for for either of these. In Tennessee, it's not really well defined right now. All right, some other issues that are common for immigrant clients is that there is a disproportional amount of immigrants in low-skill and low-pay jobs. And so what this means is that low-skill and low-pay jobs mean they have to work longer hours and usually non-standard hours, so night shift. And these jobs usually have pretty high physical demand. So this is migrant farm work, some pictures of that. And so what happens is that these clients tend to have greater levels of fatigue, lower job satisfaction, and as parents, since this was focused on pediatrics, can impair the overall sense of parenting success. I feel like I can't be a good parent to my child because I'm working all the time. Or when I am home, I'm too tired to play with them or do those kinds of things. Families also get separated commonly as immigrants. So maybe the mother and her children can come, but dad had to stay back in the home country, or vice versa. Or maybe some children can come, but not all of them. So this is very common. I see this more often than probably anything else in my own practice. And so what happens, what this means for us as providers is it means we might need to do some transnational collaborations with family members, set up some email or phone. That way we can incorporate them into the treatment, hear what their perspective is, and those kinds of things. Sometimes you can do some telehealth stuff as long as they're not the identified patient. You're not breaking any laws, but you're sort of bringing them into the session and to help with your patient, things like that. Another thing to know is that migration results in what we call this sort of change in social capital. A lot of times immigrants can sort of fit somewhere in their hierarchy in their home country. Maybe they're doctors in their home country and they come here and now they can't be doctors and they have to do something else. And so all of a sudden they've gone from being this elevated professional in their home country to now having to navigate a whole different social ladder that they're not used to being on. And so that can happen too. It's another thing to think about with your clients. It can be helpful to encourage your clients to maintain a connection to their home community. Most research has supported that that's actually a very effective response. We don't. It's good to encourage them to become a part of their new local community and get involved there, but you never want to encourage them to do that at the deficit of also losing their home connection, because that's been associated with poorer mental health. Now there are differences, however, in somebody's ability or not to engage in that local community. Maybe they're the only person of their background in that area. That can happen in rural areas. Or there may be some risk involved where the sort of the local cultural community has gang ties or something like that, and so they're hesitant to really mix with their local culture because of that. Something we do know happens is that this idea of ethnic identity is something that is really important to mental health, and I talk about it a lot in therapy with these kinds of clients. What is your ethnic identity? How do you develop this sort of strong, healthy ethnic identity? And we know that having that ethnic identity is tied to many positive outcomes, not just mental health, but all kinds of different kinds of things. But we know in childhood, ethnic identity is usually fairly rudimentary. They don't have quite as strong of an identity as an adult would, but it does get stronger over time and over age, and this is particularly true for minority youth compared to majority youth. We know that the more that parents maintain their home culture and do different kinds of things tied to their cultural themes, this increases youth ethnic identity. So again, what that translates to is, since we know that ethnic identity is associated with positive mental health, and we know that when we as providers are working with families, I get parents that ask me all the time, how my kid's being raised here, do I let them choose their own culture? Do I teach them about my culture, things like that? And I can feel comfortable telling them from a research-based perspective that, sure, the science tells us that it's good for them to hear about your home culture, and so feel free to do what you feel comfortable doing there. And that both explicit and implicit means of communicating are both strongly related to identity, so talking about it in family meetings or something like that, or just having different objects in the home is also useful. And we know that a family environment that's high in that's warm and non-controlling and autonomy promoting is also associated with ethnic pride. So this sort of gets at the other end of it, that sometimes you get parents who really try to push their ethnic identity onto their kids in a way that feels cold, or really, I don't care what you want to do. This is our history, and you're going to eat this food. Those kinds of things. And so we know that is counterintuitive. So the skill is to find a balance between the parents being able to communicate their culture and what's important, but doing so in a way that allows their child some autonomy in choosing sort of how much they want to do. Another common issue for immigrant clients is that there tends to be an increased family interdependence within immigrant cultures when you compare them to native U.S. White youth, at least. And so what this means is that the children and other members of the family tend to want to comply with parental wishes even when those parents' wishes conflict with their own. So again, this happens a lot when I'm treating, say, teenagers who have sort of their own ideas about what they want to do. We know that in some ways it's healthy for teenagers to develop this independence. I talk a lot when I'm working with parents, for example, of sort of what are the right boundaries and what's the right amount of boundaries, and how do you set those boundaries in a way that's healthy to allow them to develop some independence and autonomy, but also not just letting them go all willy-nilly with their 16-year-old brains that do stupid things. And so when you're working cross-culturally, it's also important to consider that idea too, in that we do know that, generally speaking, immigrant youth tend to want to please their parents more so than non-immigrant youth. But older youth tend to be more assertive. They'll say things like, I respect my parents, but at the same time I'm an adult and I make my own decisions, things like that. Level of differentness is another big issue. It happens more often, say, in these more rural communities where a kid might be the only ethnic kid in school, as they might call themselves. And what we know is this often results in a greater ethnic identity. They see themselves as different, and therefore they have to decide what that difference means about who they are and who they want to be. And so that can become another big part of the clinical picture, is figuring out what it means to notice that you're different, and is that okay or is that not okay? Those kinds of things. I've already said this. Secure ethnic identity is associated with good mental health. Check the time. Okay. The other thing to know is that these issues are not short-term issues for immigrants. We know that immigrant newcomers tend to experience these things for several years after immigration, sometimes even up to more than a decade. And this can be due in part to discrimination, whereas employers may want to hire a native-looking worker or a native worker compared to non-native workers. We know that having European ancestries is associated with better jobs, even after controlling for education. And so these better jobs also come with better earnings, and better earnings come with all different other kinds of advantages that are good for mental health. And so the opposite happens to immigrants. So they are sort of exposed to conditions that make it create extra challenges for mental health. There also might be differences in how immigration laws affect gender roles. As I said before, sometimes only one person in the family can get a work visa, for example. And let's say in this case it's a husband and a wife and kids, and the wife gets a work visa, but the husband doesn't for whatever reason. Maybe he's in a profession that just isn't hiring for work visas. And so the wife comes over and the husband comes over as a dependent, and now all of a sudden there's a change in his role in the family. Whereas in his culture he's supposed to be the breadwinner and provider and do all these kinds of stuff, but now he's having to be a dependent. And what does this mean for his mental health, and how does he transition that? So again, these are just other kinds of issues that might come up in clinical work that you have to consider. I'm not going to cover this. I'll just kind of summarize it for you. That there's been some psychological research that's looked about how cultural identity is formed, and essentially there's this sort of three-step phase where you come into a new culture, you notice that you're different from everybody in this new culture, and this reaffirms your original culture. You start noticing the things that are important to you in your real culture that you didn't notice before. And then the next step is you decide whether you want to keep those or you don't, and which ones you want to keep and which ones you don't. And then the last one is that eventually you make contact again with people from your original culture, and then you have to, now you're this new person that has different aspects from both cultures, and you have to figure out how to fit that in. So that's what that means in a nutshell. And again, the thing to know for us as clinicians is that can come into play just depending on where people are in their own cultural exploration of what they do. All right. I've provided this for you. I'm not going to go over it. This is something that a lawyer friend of mine who works with immigrants and helps them get status prepared. I included it in the slides for information, but I'm not going to cover it just for sake of time here today, but I wanted to keep it just so that you have it. And so he goes over different, the names of different laws, what people can do. It's basically a civics lesson. But what I did want to cover is that, no, that's not it. Refugee status, because this is some place where mental health professionals do come into play more often in this place. Because in order to to get into the country and establish a refugee status, you have to be able to testify about your persecution. And as we all know, being traumatized and persecuted creates some, let's just say, challenges in one's ability to maybe accurately create a picture and be logical and tell maybe a judge or lawyers about why they're persecuted and why they can't go back. And being able to tell all those details might be very hard for them, if possible at all. And so for that reason, mental health professionals do occasionally get asked to provide these evaluations of somebody's mental ability to testify about their persecution. So this is the definition of what it takes to mean to be put on refugee status. You have to establish that they have fear of persecution based on race, religion, nationality, or membership in some kind of social group or political opinion. So again, this is a place where this is something that mental health professionals sometimes get asked to do. Can you determine that the fear of persecution is based on this? Can you help us determine that? Help us sort through all of this trauma and background they've got to figure out if that's really the case. So one of those factors has to be the central reason for the persecution. But as I said before, they have to have the mental and emotional capacity to actually testify to that. All right, so that's really what I wanted to say about that part. There are some issues for healthcare. In a nutshell, what this says is that different people with different immigrant status can get access to different benefits. And this kind of goes over what are the different benefits and how they can apply for it. The thing to know for us is that a common misconception that immigrants have is that if they apply for benefits, that will out them as being here illegally and they'll get deported, and so they're afraid to do that. But there is actually something written within the law that says, basically, ICE has determined that they've released a memo that says they won't use any information gained through a benefits application for law enforcement purposes. So that means that we can tell our patients that yes, you can apply for benefits, and that will not be used against you, things like that. And so what that means is that can help them get insurance coverage or things like that to get health care provided for them. All right, I've talked about all this. Provider perspective. I told you I was going to touch base on what it means when providers are discriminated against. I like talking about this because it's something that I think is rarely talked about in our field. Actually, I know is rarely talked about in our field. If you do a literature search for it, you find newspaper articles and maybe a few academic papers and things like that. But really not many people say what we do. But it happens that we get discriminated against for different reasons. And most of what the clinical knowledge says is that when this happens to us, we basically are just supposed to deal with it and get over it, and that our patients have a right to discriminate against us, even though we don't have a right to discriminate against them. And that we have this duty to provide health care regardless of someone's background. But the reverse is not true to our patients. And so there, I think this was a couple of years ago. There's a link to the article there. There was a lawsuit from a black nurse toward a Michigan hospital. Basically, a family came in and said they wanted an all-white team. They didn't want any black nurses touching their babies, their newborn baby. And the hospital acquiesced this request and basically removed the black nurse from that unit. And she sued them, saying that was unfair discrimination, and she won because she was right. But there was also some arguments that the hospital may have been right, and that what would it if this nurse did touch the baby, but the family may have pitched a fit and caused all kinds of problems for everyone else, and it would just been a big mess. But it brought up this really big question of what happens when we as providers do experience discrimination, and what can we do about it? And unfortunately, there's never been an answer supplied by anyone, except for, again, that we are sort of trained as clinicians to learn how to accept it and how to sort of deal with it personally and work through our own kinds of issues and difficulties with that. I can say this is nowhere near to the level of discrimination that I just talked about, but I can say that something that happens to me as a male psychologist who works with children is that I almost always automatically get a lot of boys in my practice, because people come to me and say, I've got a boy and I want them to talk to a man, and sort of the implicit idea underneath that is that a woman would not be good enough to provide the care that this boy needs. He needs to hear it from a man, things like that. Happens vice versa on the other side. You have females that say, I won't talk to a man, I'll only talk to a female. And sometimes there's good clinical reason for that. Maybe they've experienced domestic violence, and I look exactly like their abuser, and they're not ready to deal with that. Sometimes it's just sort of lower level of gender-based discrimination. But it happens. And again, usually what happens is if we can't acquiesce to that, we do. But what I try to recommend is when possible, is to try to talk through that with your clients when they're willing to do it, and talk through what that means. If they request that, you can say, what would it mean for you if you did have a male clinician? Is there any way that you'd be willing to consider that? How can we get you to a place where you'd be comfortable with a male or a female or things like that? And I can say I've had varying experiences with that. As I said before, I worked in Hartford where people that didn't look like me, and so they'd look at me and say, "You're a rich white guy. What do you know about what it's like to be living in urban poverty?" Didn't really bother to ask actually how much money I make, which, by the way, was $12,000 in Hartford, Connecticut, which was not a lot. And so we've all been through those kinds of things. But the point is that clients make assumptions about us, thinking that we won't understand something about them. Another one that happens is they'll ask me, you work with kids, right? Are you a parent? What do you know about telling me how to be a parent if you're not a parent? Luckily, I became a parent, and so now I can say that and just avoid the conversation altogether. But other people aren't so lucky. And so, I encourage you to talk about sort of what that means and whether you can work through that. And I've had experiences where it's been beneficial, and they've said, well, I'll give it a shot, and been able to overcome some of those initial thoughts. But not always. Sometimes they stick with it and they decide not to come back, or at least not come back to you, let me put it that way. All right, another kind of thing that comes up, this will be the last thing I talk about, is when culture conflicts with the law. And this is specifically true, in my case, a lot with child maltreatment, and sort of what are acceptable cultural practices in parenting that we would consider abuse that other cultures would consider positive. So here's where I'll invite a little bit of audience participation. Does anything come to mind readily now of something that maybe you would consider to be in the area of maltreatment that maybe is acceptable in other cultures? Spanking, that's a big one. And what you spank with and where you spank and how you go about doing it. Latino families will often have this punishment of kneeling on uncooked rice. They'll put some rice on the ground and have their kids get on their knees on top of it. Leaves a lot of marks, scratches. It's pretty painful. You can have cultural differences in when it's acceptable to leave the child unattended at home. This happens more in rural cultures too, I've seen, where they'll say, you know, he's 7 now. He's okay to stay home by himself for a couple hours while I go out and do stuff. Whereas I think, you know, 7-year-old can do a lot of damage in 2 hours. That's maybe not a good idea. But in other cultures that might be acceptable. I've heard about other extreme examples. I'll just give a quick story of the most memorable one that I read about in a book somewhere, where this father came from a culture where what you were supposed to do was, the mark of a good parent would be that they had this tradition where you clean the dirtiest part of your baby with the cleanest part of yourself. And so I can't remember what culture he's from or how the reasoning worked out, but basically the dirtiest part of his baby was his son's penis, and the cleanest part of him was the inside of his mouth. And so he took a picture of himself cleaning his baby's penis with his mouth and put it in their family photo album and left it on the table, and this other person came over to their house and they were showing them how proud he was and how good of a dad he was with this photo album, and this picture came up, and so this person reported it. It went to, I think it made it all the way up to a state Supreme Court. Eventually found, he was not charged with anything. It was eventually found to be an honest mistake, and not knowing what's acceptable in our culture and what's not. But again, obviously that's something that for most of us are like, what the hell, that's weird. But for him, he thought he was really being a good dad, and he was doing the best thing he could for his child. So things like that can happen, and so these are things you can think about as we're talking about parenting decisions and things that people make. All right, that was everything I wanted to talk about. You have questions or anything else? I forgot my shameless self-promotion. As I was preparing this, I realized I'm not above self-promotion. So I'm doing a research study now over on the main campus where I'm having a whole lot of trouble finding kids that participate, so I thought I'd at least announce it so that more people are aware of it. You can send kids if you want to or not. It's all up to you. But I research self-development in kids, so this has a little bit about to do with some of the things I talked about with culture and sort of how does culture impact someone's sense of self, and how do they develop their sense of self. And specifically, I'm looking at how do different models in their life. So, for example, if a kid perceives themselves as having poor proximal role models, being like their family or things like that, do they reach out to celebrities or fictional characters? When they say things, I want to be like Katniss, or I want to be like LeBron James, even though they don't really know anything about these people. What does that mean? Things like that. So anyway, so that's what I'm researching. That's what the study's about. So I'm looking for kids between ages of 6 to 17 to come to me for an hour and get $10. So just wanted to let you all know about it. If you can think of any kids that you think might be willing to participate, then just have them contact me. I can tell you more. Or if you have more questions, let me know. All right. Thank you all.
One of the things about immigration that I thought to ask was, having worked for a long time in Miami, immigration is not necessarily an acute phenomenon. And working with the Cuban population, particularly there, you're talking about several different waves of immigration, like when Castro first took over versus the Marielitos, for example, big differences in the characteristics of these waves of immigrants from the same country. And so I thought I would ask you about that, as well as, partly related to that, intergenerational differences in cultural change in terms of acculturation to the majority culture. And so for Cuban immigrants, many times the disparity between the generations related to cultural values was so great that it caused psychiatric disorders, substance use disorders, particularly in teens, being common. And just thought I would ask you about that as well.
Yeah, I mean, I've seen exactly what you're talking about. I see it all the time. These kinds of, this idea of why do people immigrate and where they're coming from and how that contributes to, so in your case you're talking about Cubans and sort of the difference of, where they, I imagine in their case a lot of them were leaving for safety reasons, but some of them were leaving for other reasons, and they were, and in Miami they were able to find a community of other people like that, and sort of how that contributes to their mental health. So I'll say I've seen similar kinds of things where if you look inside immigrant communities, you can see some pretty typical types of presentations, some more common kinds of things. As you've said, I've seen substance use. I see a lot of anxiety, and usually based around their new status and their security. Things like that. And so, yeah, I guess I don't really have an answer, but I agree that I've seen it. Yeah.
Okay. Well, thank you very much, and thank you for the talk today.